Hey health champions, so have you ever had a patient who was shocked to find out they had diabetes during pregnancy, even though they had no history of it? That's gestational diabetes mellitus, or GDM. It's a temporary condition, but honestly it can have lasting implications if it's missed or not managed well. Today we're going to talk about what causes GDM, how to catch it early, and how nurses can support moms and babies through this unique journey. Gestational diabetes. Mellitus is a type of glucose intolerance that develops during pregnancy, usually in the second or third trimester. It happens because placental hormones like human placental lactogen increase insulin resistance, which ends up raising maternal blood glucose levels to help nourish the baby. But in some women, the pancreas just can't keep up, leading to hyperglycemia. Universal screening is done between 24 to 28 weeks gestation. There are two approaches. First, the one-step 75-gram oral glucose tolerance test, where fasting is greater than or equal to 92 milligrams per deciliter, 1 hour is greater than or equal to 180 milligrams per deciliter, and 2 hours is greater than or equal to 153 milligrams per deciliter. Second, the two-step method, 50-gram 1-hour glucose challenge, and if it's greater than or equal to 140 milligrams per deciliter, you follow with a 100-gram 3-hour OGTT. Diagnosis is confirmed if 2 or more values exceed the thresholds. So let's talk about managing gestational diabetes mellitus. First up, diet and lifestyle modifications are key. Medical nutrition therapy, or MNT, should be guided by a dietitian, focusing on complex carbohydrates, lean protein, and healthy fats. It's important to have frequent small meals throughout the day, plus a bedtime snack. Physical activity is also really important. Aim for at least 30 minutes of moderate exercise on most days, as this helps reduce insulin resistance. On top of that, blood glucose monitoring is crucial. You'll want to check fasting levels, and also 1 or 2 hour postprandial or after-meal values. The targets are fasting less than 95 milligrams per deciliter, 1 hour post-meal less than 140, and 2 hour post less than 120. If lifestyle changes aren't enough to keep blood sugar in range, pharmacologic therapy comes into play. Insulin is the first-line treatment, but in some cases, medications like metformin or glyburide might be used, though those aren't the first choice. Now, when it comes to fetal surveillance and planning for birth, monitoring fetal growth with ultrasound is essential. If gestational diabetes isn't well controlled, non-stress tests or NSTs may be recommended. Delivery is usually planned around 39 to 40 weeks if everything is stable, but it could be earlier if any complications arise. So, let's talk about nursing care and patient education. First, it's really important to teach self-monitoring of blood glucose. You'll also want to review food logs, meal planning, and carbohydrate counting with your patients. And don't forget to reinforce the importance of consistent meals and avoiding sugary drinks. Monitoring maternal weight and fetal well-being is essential too. Finally, be sure to prepare the patient for insulin self-injection if it's needed. Gestational diabetes usually resolves after birth, but up to 50% of women will develop type 2 diabetes later on. So it's key to schedule a 6 to 12-week postpartum glucose test, called an OGTT. Also, encourage a long-term healthy lifestyle and make sure to recommend annual diabetes screening. Gestational diabetes may end after pregnancy, but the education and habits built during it can honestly last a lifetime. Nurses, your teaching today really lays the foundation for a future free of chronic disease. What's your best way to explain GDM to expecting moms? Share your teaching tips below. Like, subscribe, and follow for more maternal care insights, because every mom deserves a healthy pregnancy and a hopeful tomorrow.